I'll send the link. Connect to stream. From YouTube channel.
Okay.
But I'll share it. भाई आजाद आज आवाज ठीक आ रही है? हेलो. So my voice is not breaking, right? Guys, my screen is visible. Okay, cool. So we'll start in 2 minutes, okay? We'll wait for others to join. We'll start in 2 minutes. Before 5. Okay, let's start. Okay. So today we'll try to cover endocrinology and nephrology. Okay. So let's start with all the endocrine glands. So for Krok exams, we have to know about, for Krok 2 exam, we should know about pituitary gland. We should know about pancreas, adrenal gland, and thyroid. These are the 4 main endocrine glands we should know about, and we don't need to know all the pathologies related to these glands. We'll just focus on all the topics which have come in Krok 2 exam. Okay, so for pituitary gland, the important ones are Sheehan syndrome, this prolactinoma, and hyperprolactinemia. Hyperprolactinemia. Okay, these prolactinoma and hyperprolactinemia, they are different things. Okay, I'll explain these. So we'll start with Sheehan syndrome. So I hope you all remember, like we discussed in gynec module, that what is Sheehan syndrome. So Sheehan syndrome is postpartum hypopituitarism. So I'll quickly revise this thing is, so during delivery, if there's massive hemorrhage, if there's delivery, there's massive bleeding, so there's maternal blood loss, right? Blood loss. And usually in Krok questions they give like there's 1.5 to 2 liters of blood loss during delivery. Blood loss. Okay, during delivery. So after this blood loss there was ischemia of pituitary gland. I hope all of you remember like why there's ischemia of pituitary gland, especially, not other organs. Okay, because during pregnancy there's enlargement of pituitary gland by 50%. Okay, so there was ischemia of pituitary gland and it was causing hypopituitarism. So if hypopituitarism, there will be less gonadotropin releasing hormone, less LH, FSH. Okay, there will be less prolactin. So all of the pituitary hormones, they will be less. Okay, so there will be amenorrhea. Okay, in the patient after delivery, right? So even after 1-2 years, not physiological amenorrhea which we usually see for 6 months. Okay, so these are the main signs of Sheehan syndrome, and we already discussed them in gynec in depth. Okay, I'll just remind you, the investigation of choice was we were checking gonadotropin levels. So we can check gonadotropin levels in blood, right? So this was about Sheehan syndrome. Then, so Sheehan syndrome we discussed mainly in gynec module. Now I was just reminding you this syndrome. Okay, so this is important syndrome of pituitary gland. Then prolactinoma also we discussed in gynec, right? Prolactinoma is a pituitary tumor producing prolactin hormone, right? So this pituitary tumor producing prolactin hormones, we call it prolactinoma. So what will be the clinical features of prolactinoma? So if there's prolactin increase, it will cause milk discharge from mammary glands. Without any pregnancy, there will be milk discharge from mammary glands. This prolactin also inhibits secretion of GnRH, gonadotropin releasing hormone, which will cause decreased LH, decreased FSH. So there will be no menstrual cycle. So there will be amenorrhea in the patient. Right? And as this is a pituitary tumor, so there's enlargement of pituitary gland in the brain, right? So there can be some pressure symptoms also in the brain. So patient might feel headache. There can be disturbed vision also. Okay. For treatment of prolactinoma, so many students, they are confused in the treatment of prolactinoma. So for prolactinoma treatment, we use D2 agonists. So we use dopamine agonists, right? Why do we use dopamine agonist? Is dopamine inhibits prolactin release in the brain. Right? So if we will give dopamine, it will inhibit the prolactin release. So all the symptoms, all the sign and symptoms due to increased prolactin will be reduced. Okay, so what are the dopamine agonists we know? There's bromocriptine and cabergoline. Okay, this Sheehan syndrome and prolactinoma we already discussed in gynec module. Okay, so that this third thing, hyperprolactinemia. See, what is hyperprolactinemia is there's increased prolactin, but this is not like this is not necessarily related to pituitary tumor. Okay, so I'll give you an example. Okay, in when we were talking about hypothyroidism. Okay, in hypothyroidism there's less T3, less T4, and there was increasing thyroid stimulating hormone. Okay, there was also increasing thyroid releasing hormone TRH, thyrotropin releasing hormone. This TRH increase was causing TSH increase and prolactin increase. Right, this can cause hyperprolactinemia, but this is not related to pituitary tumor, right? Then what apart from hypothyroidism, if patient is taking dopamine antagonists, so there will be inhibition of dopamine receptors on brain, and there will be increased prolactin level. Okay, so it is not necessary that if prolactin is increased there will be only like prolactinoma. There can be hypothyroidism, there can be dopamine antagonists also usage. Okay, so in hyperprolactinemia all clinical features will be due to increased prolactin only. So milk discharge will be there, discharge from breasts. There will be amenorrhea because of decreased GnRH. Then how it is different from prolactinemia is if you do MRI will be usually normal because there's no pituitary enlargement, right? And there will be no headache, no visual impairment. I hope till now we are clear with pituitary gland pathologies. Okay, so we have discussed about Sheehan syndrome. Okay, so the most important thing about Sheehan syndrome is it is postpartum hypopituitarism. So there's decreased pituitary gland function after delivery. Okay, and this occurs because of massive bleeding. Okay, massive hemorrhage during delivery. This is ischemia of pituitary gland, and there will be all of the pituitary gland hormones will be decreased. Okay, hypoprolactinemia, GnRH decreased. There will be decreased ACTH, decreased cortisol will be there. Okay, like this. So for prolactinemia, it is a pituitary tumor in which there's increase in prolactin hormone. So all the clinical features will be because of increased prolactin, right? Milk discharge, so amenorrhea will be there. You will do pituitary. For the pituitary tumor, there will be headache, disturbed vision. In MRI, you will see enlarged pituitary gland, because this is a pituitary tumor, right? And the treatment will be dopamine agonists. So you will stimulate the dopamine receptors so that dopamine will inhibit prolactin release, and all the signs and symptoms will be decreased in the patient. Hyperprolactinemia, there can be hypothyroidism which causing hyperprolactinemia. A patient using dopamine antagonists might get hyperprolactinemia. All the clinical features will be same except headache and visual impairment, and MRI will be normal in these patients. Okay, I hope we are this thing is understandable. Okay, this pituitary. Now let's move to adrenal pathologies. For adrenal gland, what's important is we have to see Cushing's disease, Cushing syndrome. Okay, these things so very important. let's start with Cushing disease. Okay, so we were discussing about pituitary tumor. Okay, so this pituitary gland, it secretes many hormones, right? ACTH, then TSH. So it stimulates thyroid hormone, adrenal cortex. Then it secretes gonadotropin releasing hormone. So there are many hormones releasing by pituitary gland. If there's increase of prolactin due to pituitary gland, we call it prolactinoma, right? If this pituitary tumor is producing excess ACTH, okay, we call it Cushing's disease, right? Cushing's disease. Okay, Cushing syndrome. So any syndrome is group of symptoms. Group of symptoms. See, so group of symptoms due to increase of cortisol, we call Cushing syndrome. So I'll try to differentiate between them. Okay, see, in any patient, okay, let's say we have a patient X. Okay, he has increased cortisol by any reason, by X, Y, Z. Like there can be many causes for increase of cortisol in any patient, right? And then the patient is getting some group of symptoms, like there's centripetal obesity. Centripetal obesity means this is head, this is abdomen, these are small legs. Okay. Centripetal obesity means there's increased fat in the abdomen, in the thorax cavity. So there's like lemon on stick appearance. We usually call them, right? So apart from centripetal obesity, there will be bluish stria, bluish stretch marks, on abdomen, there can be frontal bone bossing. Frontal bone bossing means there's like this frontal protuberance, they are very enlarged. Okay, there can be hypertension, hyperglycemia. So these are the main sign and symptoms for Cushing syndrome. If these sign and symptoms are present, we call it Cushing syndrome. Okay, so Cushing syndrome is due to increase of cortisol, right? And this cortisol can be increased because of many reasons. So causes for Cushing syndrome is, see, if some doctor is prescribing more cortisol to the patient, there will be iatrogenic Cushing syndrome, right? There can be primary hypercortisolism. So if there's any tumor of adrenal gland, it will produce more cortisol, right? If there's production of more ACTH from pituitary gland, so if there's increased ACTH from pituitary gland, there will be increased cortisol, and this we call it Cushing's disease. So Cushing disease is one of the cause of Cushing syndrome. Okay, so Cushing disease is, we only call Cushing disease when there's increased ACTH by pituitary gland, and which is causing Cushing increase in cortisol, right? In all other causes, there will be increased cortisol but decreased ACTH, right? Okay, so there can be numerous causes for increased cortisols, and one of the common cause for Cushing syndrome is Cushing disease. So I hope like you got the main idea, the main difference between Cushing disease and Cushing syndrome. Okay, so Cushing's disease. So I told there will be increased ACTH, there will be increased cortisol. So this ACTH will stimulate adrenal cortex to increase the production of cortisol. So right, so there will be all sign and symptoms because of Cushing's disease, so similar to Cushing syndrome. And there will be sign and symptom because of increased ACTH also, which is hyperpigmentation. Hyperpigmentation, right? So in Cushing disease, there will be hyperpigmentation with all signs and symptoms of Cushing syndrome. Okay, and in Cushing syndrome, signs and symptoms we talked about, there will be centripetal obesity, there will be striacutis, which we get in Krok question. They mention striacutis. Okay, there can be frontal bossing, there can be hypertension, there can be hyperglycemia, right? Amenorrhea can be there. Why amenorrhea we discussed in gynec module. Okay, that's it. So I hope like you got the basic difference between Cushing syndrome, Cushing disease, and now you can diagnose Cushing disease syndrome. Okay, see this. Let's say this is adrenal gland. Okay, so in adrenal gland, I'll quickly go through this anatomy. Okay, I won't take much time. So in adrenal gland, in the center we have medulla, and in the cortex we have three layers. We have zona glomerulosa, zona fasciculata, and zona reticularis. So these all layers are adrenal cortical layers, adrenal cortex. Okay, so we know from the outermost layer, from this layer, from outermost layer, there's secretion of mineralocorticoids. There's secretion of aldosterone, right? From this middle layer, fasciculata, we get cortisol, right? And from reticularis, we get androgens. From medulla, there's secretion of epinephrine and norepinephrine. Norepinephrine. Just remember this thing because this is very important for our like I'm going to explain about Addison's Cohen's syndrome. Okay, so it will be important for you. About Pheochromocytoma, this diagram is important. Okay, so we have talked about hypercholesterolism. Okay, see, if there's aldosterone pathology, what aldosterone is, so let us start with the function of aldosterone. Okay, see, we all know aldosterone, it is released by zona glomerulosa of adrenal cortex, and it usually acts on kidney tubules. It acts on renal tubules, right? So what is the function of aldosterone is, it increases sodium reabsorption. So if there will be increased aldosterone in any case, there will be definitely increased sodium also in the serum, and it increases potassium excretion. So there will be more potassium loss with urine. Okay, so there will be decreased potassium in serum. So in any case of hypoaldosteronism, hyperaldosteronism, okay, there will be increased sodium and there will be reduced potassium levels, right? So this is hypernatremia we get in the patient of hyperaldosteronism and hypokalemia, right? Because of this hypernatremia, we can also get hypertension in the patient, because if there will be more sodium in the blood, there will be more water in the blood, and it will cause hypertension in the patient. So if in any question you get sodium level more and potassium level less, definitely it's going to be hyperaldosteronism. Okay, what all can be written in Krok question is, they can write this as hyperaldosteronism or Cohen's syndrome. Cohen's syndrome is also hyperaldosteronism, primary hyperaldosteronism, or they can write it primary hyperaldosteronism. Some place they'll write it aldosteroma. Aldosteroma. Aldosteroma means there's increased aldosterone. So there's any tumor producing aldosterone. Okay, so these three can be there, and they all mean that there's increased hyperaldosterone in the blood, which is causing hypernatremia and hypokalemia. Okay, so here I'll tell you the normal values of sodium in the blood is 135 to 145, and for potassium it's 3 to 5. Okay, so if it's more than 5, if there's more than 5.5, we usually call it hyperkalemia, and less than 3 we call it hypokalemia. So here it will be less than 3 in our case of Cone syndrome, and for sodium level they will be more than 145. Okay, and there will be hypertension also. Understand? So if there's hyperaldosteronism, right, we call it Cone's syndrome. Cone's syndrome. There can be some condition with causing hypoaldosteronism, right, and this will be called as Addison's disease. Addison's disease. Addison's disease. So if there will be decreased aldosterone, there will be decreased sodium also, and there will be increased potassium, more than 5.5 and less than 135, right, and there will be hypotension. See, if there will be less sodium, there will be less water in the blood, and the blood pressure will drop. So in any sodium potassium pathology, you should always think about aldosterone levels. Okay, if sodium level is high, increased, there will be increased aldosterone level also. Okay, so it can be Cone syndrome, right? So we have discussed about, yes, so we are done with aldosterone disease and cortisol. For Krok, they have never asked about androgen disorders. Okay, so we'll move to adrenal medulla. Guys, any doubts still here? No, right? Okay. So we'll move to pheochromocytoma. Pheochromocytoma. See, if by anyhow there's increased epinephrine and norepinephrine release, okay, by adrenal medulla. See, if there's hyperplasia of adrenal medulla, or there's tumorous growth for adrenal medulla, there will be increase or epinephrine and norepinephrine, and we call it pheochromocytoma. So how it like how what will be the clinical features? What will be the clinical presentation of the patient? See, firstly I'll tell you this thing is, shit, where is it? See, this adrenal cortex, it usually works all the time. Works all the time. What does it mean is, see, if there's ACTH stimulation on the cortex, so adrenal cortex will continuously try to secrete, to try to form this cortisol. Okay, so there will be continuous cortisol release in the blood, right? But adrenal medulla, it works in pulsatile manner. It works in pulsatile manner. What does it mean is, so now let's say adrenal medulla has released some amount of epinephrine, norepinephrine in the blood, and it will release next amount, like next time epinephrine, norepinephrine after 3 hours, 6 hours. So it works in pulsatile manners. Okay, so there's no continuous release of epinephrine, norepinephrine from adrenal medulla. Okay, so the clinical features will be, due to increased epinephrine and norepinephrine, is pulsatile headache. Okay, so headache will come and go. Okay, like this. So there will be hypertension can be there. But all the symptoms usually are pulsatile. Okay, so there will be tremors. So tremors will come and go. at the time of increased epinephrine, norepinephrine in the blood, there will be sweating, there will be tremors. Okay. There can be hypertension, tremors, sweats, hyperglycemia in the patient. Okay, so these are usually the clinical features for pheochromocytoma, and these are because of increased epinephrine, norepinephrine. Okay, for investigation, of pheochromocytoma, we can do urinary vanillyl mandelic acid. Just remember the name, because in the Krok question they have mentioned a patient of pheochromocytoma, all the clinical features they have given, and then they said like there's increased urinary VMA levels. Okay, why these urinary levels are? See, there's increased serum epinephrine and norepinephrine. Now after their function they will degrade, right? Every protein will degrade after its function, and they degrades in VMA, vanillyl mandelic acid, and this is excreted by kidney. So in the urine level you can find increased VMA levels, or there will be serum epinephrine, norepinephrine increased. Okay, so this is about investigation, right? For treatment, see, it usually stimulates alpha receptors, beta receptors, right? So this is the basic function of sympathetic nervous system, to stimulate alpha receptors, beta receptors, and these increased epinephrine, norepinephrine are also doing the same thing. That's why we are getting symptoms in the patient of pheochromocytoma. So for treatment of pheochromocytoma, we usually use alpha receptor blockers. And the drug of choice for pheochromocytoma is also starts from P, which is phentolamine. Okay, this drug they have asked, okay, in the Krok exam. So phentolamine is used for treatment of pheochromocytoma. Okay, and this is alpha receptor blocker. Cool. So in adrenal gland, we have talked about Cushing syndrome, Cushing disease. We have talked about cones. We have talked about Addison. Addison is hypoaldosteronism and cone is hyperaldosteronism. And we have talked about pheochromocytoma. Right. What else is left there? We'll talk about CAH right now. Okay, what is CAH? Is congenital adrenal hyperplasia. So I've got doubt on this topic, especially, okay, from many students. So what is congenital adrenal hyperplasia? Just try to understand. Okay, see, definitely from you can you can remember all the sign and symptom by its name only, okay, and you can know all thing about it, all about this disease by its name. See, this is congenital disorder, first of all. Okay, so this will be seen in children or newborn, because this is congenital, so all the clinical features they will be seen in newborn or children. Okay, and there's adrenal hyperplasia, so there will be enlarged adrenal cortex. Okay, see, the main pathology in CAH, that is congenital adrenal hyperplasia, is their disturbed cortisol formation. Anyhow, okay, most commonly there's 21 alpha hydroxylase enzyme deficiency. See, there's an enzyme deficiency which is causing disturbed cortisol formation. So there will be decreased cortisol formation. Okay. If there will be decreased cortisol, so the pituitary will increase ACTH release to ask adrenal cortex to make cortisol. Okay, so there will be increased ACTH, right? So there will be increased ACTH and decreased cortisol. So this will be seen in all types of CAH. Okay, this thing is constant. Decreased cortisol and increased ACTH, and there can be decreased aldosterone also. In this enzyme 21 alpha hydroxylase we get decreased aldosterone also. Decreased. Okay, so you can make the clinical presentation by yourself. There will be case of newborn or some child. Okay, younger age group. The patient will present with, due to increased ACTH there will be hyperpigmentation, and due to cortisol there will be other signs where there can be hypotension in the patient, right? There can be weight loss, hypoglycemia can be there in the patient. So these all can be due to decreased cortisol, and if aldosterone is decreased there will be decreased serum sodium, increased potassium. So decreased sodium will cause to hypotension and increased potassium will cause arrhythmias, right? So this is an enzyme deficiency where we get decreased cortisol production and sometimes decreased aldosterone also. Okay, this is plus minus, and there will be definitely increased ACTH. So if there is ACTH increased, why is BP always high in pheochromocytoma? So in pheochromocytoma BP is always high because of increased sympathetic nervous system activity. Okay, so we were discussing about CH na. So there will be decreased cortisol, there will be increased ACTH. Because of increased ACTH there will be hyperpigmentation. Because of decreased cortisol you will get hypotension, weight loss, hypoglycemia will be there. Okay, and because of decreased aldosterone there will be hyponatremia and hyperkalemia, right? So we were discussing that, see, we all know this this cortisol. Okay, cortisol is formed from cholesterol, and there are many steps between these, right? And one of the step is there's formation of 17 hydroxyprogesterone, and it converts to other intermediate enzyme. Okay, intermediate product. Here we need 1721 alpha hydroxylase. See, if there's deficiency of this enzyme, this particular enzyme, it will lead to this intermediate increase in blood. Okay, so for screening of CH, for screening of CAH, for diagnosis we check for serum 17 hydroxyprogesterone levels, and if they are increased, so we can know like the patient might be suffering from hypocholesterolemia or congenital adrenal hyperplasia. Okay, so this is the screening thing. We have not missed anything, right? Congenital hypo, yes. So screening thing is done. Okay, so we are done with adrenal gland. So in adrenal gland we talked about Cushing disease, Cushing syndrome, Cone syndrome, Addison's, then Pheochromocytoma and CAH. Okay, let's move to thyroid pathology. Thyroid pathologies. Okay, so before starting thyroid gland pathology, okay, I'll quickly tell you some regulation of thyroid hormones. See, we have hypothalamus at the top, right? I'll make it like this. We have hypothalamus, then we have pituitary gland, and then we have thyroid gland. Right, we all know this thing. See, this hypothalamus, it stimulates pituitary with TRH, thyrotropin releasing hormone. Okay, thyrotropin releasing hormone, releasing hormone. Then pituitary secretes thyroid stimulating hormone, TSH, stimulating hormone. And if there's increased TSH, okay, this TSH will work on thyroid gland and it will cause increased T3 and T4 production in blood. Right, so this is very basic thing. Okay, so now if by anyhow there's decreased T3, decreased T4, we call it hypothyroidism. Hypothyroidism. Right, if there's decreased T3, T4 due to thyroid pathology, it will cause increase in TSH, because pituitary gland will tell the thyroid to release more T3, T4, but there's some pathology of thyroid gland, so there will be decreased T3, T4 because of some thyroid issue, and there will be continuous TSH increase. This we call it primary hypothyroidism. Primary hypothyroidism means there's some issue with thyroid gland. Okay, if there's decreased T3, T4, we call it hypothyroidism. But if there's decreased TSH also, see, if there's some pituitary gland pathology, so TSH is not releasing only from pituitary gland, and there will be decreased T3, T4 because there will be no stimulation on pituitary gland, on thyroid gland, right? So we call it secondary hypothyroidism. If there's pathology of thyroid gland, we call it primary disorder, right? If there's pathology of pituitary causing decreased or increased thyroid hormones, we call it secondary disorder. Okay, so I'll quickly make a table here. If there's decreased T3, T4 and decreased TSH, there will be secondary hypothyroidism we discussed, right? Decreased T3, T4 and increased TSH, there will be primary hypothyroidism. And this primary hypothyroidism question they have asked in Krok exam already. Similarly, if there's T3, T4 increased, we call it hyperthyroidism. So if the arrows are opposite, we call it primary hyperthyroidism. See, if both arrows they are in the same direction, we call it secondary disorder. Hyperthyroidism. Hyperthyroidism. Okay. And if there will be T3, T4, TSS, we call it secondary hyperthyroidism. I hope this thing is clear. Okay. See, so now we'll talk about hypothyroidism sign and symptoms. So I'll quickly tell you hypothyroidism sign and symptoms, then we will move to what can be the cause of hypothyroidism, that is Hashimoto thyroiditis in our case. Okay, so thyroid hormone, it increases, it boosts the metabolism of human body. Okay, so if there will be decreased thyroid, there will be decreased metabolism of the patient. So because of decreased metabolism, so there will be decreased metabolism, there will be weight gain, appetite loss, right? There will be dry skin, there will be somnolence, so the patient will feel sleepy all the day. Somnolence. Okay, there will be bradycardia, the heart rate will also drop, there will be hair loss, hypothermia. So these all are the signs and symptoms for hypothyroidism. Okay, if this hypothyroidism, so there can be many causes for hypothyroidism, right? If this hypothyroidism is caused by some anti-thyroid antibodies, see, if by anyhow there's formation of anti-thyroid antibodies, okay, and these are damaging thyroid gland, so it will cause hypothyroidism. We call it Hashimoto's thyroiditis. So I'll explain it again. Is what is Hashimoto thyroiditis is there's formation of anti-thyroid antibodies. So there's formation of some antibodies which are damaging thyroid gland, and there's lymphocytic infiltration in thyroid. See, if this is thyroid gland, right? So there are damage due to antibodies, right? So antibodies, they are damaging thyroid gland, and there's infiltration of lymphocytes also. So lymphocytes are also infiltrating, and they are also damaging thyroid gland. If there's lymphocytic filtration, there's anti-thyroid antibodies, so we know there will be decreased T3, T4, right? So decreased thyroid function, and we'll get all the signs and symptoms of hypothyroidism, and this condition we know by the name of Hashimoto thyroiditis. Okay, I hope this Hashimoto thyroiditis is clear. Okay, there will be thyroid gland enlargement also, because there's lymphocytic infiltration. Okay, in hypothyroidism we also get amenorrhea. For treatment of hypothyroidism, we all know we'll give thyroid replacement therapy. And what thyroid replacement therapy is, we give L-thyroxine, levothyroxine to the patient to replace the if there's decreased thyroid hormone release in the blood, so we'll replace it. Okay, we'll go in thyroid replacement therapy or thyroid supplementation. Okay, all the features in hyperthyroidism will be because of increased metabolism. So there will be increased T3, T4, and this will cause increased metabolism. Right, there will be increased metabolism. So in the clinical feature, there will be weight loss, increased appetite. So we call it like there's increased appetite and still there's weight loss. So this should be considered as hyperthyroidism. Okay, there's increased appetite, there will be sweaty skin, right, tachycardia, palpitation. This hyperthyroidism can also cause atrial fibrillation. Okay, so the heart rate might go very fast and it will cause atrial fibrillation. Okay, and here also there can be enlarged thyroid gland. Okay, so hyperthyroidism, you can easily diagnose hyperthyroidism by these clinical features. There can be weight loss, appetite increase, sweaty skin, so there will be wet skin, tachycardia, atrial fibrillation, palpitation, and last thyroid gland, right? So what can cause hyperthyroidism? Okay, so for Krok to there's important causes are there can be Graves disease, and there can be diffuse toxic goiter. So I'll tell you the difference between these. Okay, see, we also get exophthalmia. Okay, so the eyes will be bulging eyes, we call them bulging eyes, right? So let us talk about Graves disease. So in Graves disease, there's production of thyroid stimulating immunoglobulins, right? So there are formation of some antibodies, they are not damaging thyroid gland. So in Hashimoto thyroiditis, there were also production of antibodies, but they were damaging, so they were anti-thyroid antibodies, right? In Graves disease, we get thyroid stimulating immunoglobulins, thyroid stimulating antibodies. So they will works similar to TSH. They will stimulate production of T3 and T4, right? So there will be TSIs causing T3 and T4 increase, right? So there will be all signs and symptoms of hyperthyroidism. See, in any patient of hyperthyroidism, you are getting TSIs. You will suspect Graves' disease, right? Graves' disease. If there's diffuse enlargement of thyroid gland, diffuse enlargement, and in there you're getting multiple adenomas. So there's multiple foci of increased thyroid hormone production. There are multiple foci which are producing more thyroid gland, okay, more thyroid hormone. So there's increased T4 and T3, and there's diffuse enlargement of thyroid gland. Okay, and these are given signs and symptoms of hyperthyroidism. Okay, there are multiple adenomatous growth, right, in thyroid gland. So you'll feel multiple nodular growth in thyroid gland. So we call it diffuse pin. Wait. See, in Hashimoto also there can be painless growth, right? Just like in goiter. Okay, so there can be painless growth in this Hashimoto's disease. Okay. There be pain? No pain in Hashimoto usually. Okay, we'll call it diffuse toxic goiter. So why we are calling diffuse is there's diffuse enlargement of thyroid gland. Why we are calling it toxic is there's hyperthyroidism. Diffuse toxic goiter. Okay. So I hope there's like the basic difference between Graves' disease and this diffuse toxic goiter is clear. Okay. See. So I've told you for diagnosis of Graves' disease you usually go for TSI. Okay. For diffuse toxic goiter you do thyroid scan. Okay. So they are this iodine 131, iodine 123, right? So you give that to the patient and you do the scanning of the thyroid gland. So in the Krok question they might write it as gland scanning, and this we usually do for diffuse toxic goiter. Okay. For treatment of hyperthyroidism, see, if there's increased thyroid production, we can use some or anti-thyroid drugs, right? What anti-thyroid drugs means, they will damage the thyroid gland till some extent. Okay. And what are the most common these drugs? Mercazolil, right? Mercazolil, though it is very commonly used for like this is very commonly used in Ukraine. Okay. And we can also use propyl thiouracil, PTU. So for Krok question, for any hyperthyroidism patient, first of all go for mercazolil. Okay. Apart from anti-thyroid drugs, we can use propranolol. So now why we are using propranolol is it inhibits peripheral conversion of T3 to T4. See, so whenever this thyroid gland, it secretes the thyroid hormones in the blood. It is mainly in the form of T3, and in the peripheral tissues it is converted to T4. So mainly T3 is released from thyroid gland, and wherever it has to act, let's say in the heart, in the muscles, okay, it is converted to T4 over there. So propranolol, it inhibits conversion of T3 to T4, and there will be no symptoms, okay, at all. and the definitive treatment will be surgery, right? So if there's like a lot of symptoms of hyperthyroidism and they are not tolerable to the patient, we'll do surgery. So for surgery we will do thyroidectomy, right? So what can be the complications during surgery, after surgery, pre-op? Okay, so we'll discuss about them. See, we talked, like, let's say there's thyroid gland enlargement, okay, and a surgeon is preparing on that. So this thyroid gland, it has a lot of thyroid hormones inside it, right? There are a lot of thyroid hormones inside it. So let's imagine that somehow these thyroid hormones during surgery, they have come out, right? By somehow these thyroid hormones have come out of thyroid gland and into the blood. Now they will cause thyrotoxicosis, thyrotoxicosis, right? Thyrotoxicosis, right? Thyrotoxicosis. So if by anyhow during surgery, just post-op, okay, or pre-op in the period, there can be a complication known as thyrotoxicosis. Right? Thyrotoxicosis means there's sudden increase of thyroid hormones, sudden increase of T3, T4 in blood, and there will be very high temperature in the patient. There will be tachycardia. So there will be sudden signs of acute signs of this hyperthyroidism. We call it thyrotoxicosis or crisis. Thyroid crisis. Okay. Apart from this, let's say you have done a thyroidectomy in a patient. Okay. So after thyroidectomy, there will be no place for thyroid hormones to be released, right? So there will be hypothyroidism. So we call it post-operative hypothyroidism in the patient. So if there will be post-operative hypothyroidism, how can you treat it? You can give levothyroxine. Okay, replacement therapy. Okay, and apart from this, during surgery, there can be damage to recurrent laryngeal nerve. See, there can be some nerve damage, right, during surgery. So this recurrent laryngeal nerve is it usually innervates this larynx. Okay, so there will be symptom of hoarseness in the patient. So if there's hoarseness in the patient, so they can ask you which laryngeal nerve is usually damaged during thyroid surgery, which has caused hoarseness of voice. Okay, and the answer will be recurrent laryngeal nerve. So in thyroid pathology, we have talked about Hashimoto, we have talked about Graves' disease, and this diffuse toxic goiter. Okay, any doubts till here? Pain differential diagnosis necessary in thyroid patient. So this pain differential diagnosis is not necessary. They will usually give the keywords, okay, for the diagnosis. For if they are giving hypothyroidism symptoms, they'll usually give this anti-thyroid antibodies also. So you might think of Hashimoto. Okay, this renal thyroiditis can be painful, okay, but they have never asked about renal thyroiditis for Krok. Cool. So we're done with hypothyroidism and hyperthyroidism. Let's move to this thyroid cancer ones. Thyroid cancer. See, if there's thyroid enlargement, okay, thyroid enlargement, and if see the general signs symptoms of cancer we all know, right? There's weight loss, there's asymmetrical growth, usually painless, these things. Magnesium for thyroxine. Management for thyroid problems. Not understanding. Levothyrox. Bro, Shashank, bro, please write complete. Now you are asking about management for L-thyroxine. Okay. Just write your question properly, na, so that I can understand them. Okay. So this thyroid cancer. Okay. So we all know the cancers. Okay. They usually are painless because they don't want the body to know that some pathology is going on. Okay. So they are usually painless, asymmetrical. There's weight loss. Dose of thyroid levothyroxine. Okay, so I'll tell you the dose. Wait, dose of levothyroxine. See, usually levothyroxine doses we divide into three parts. Okay, there's a replacement. There, wait. There's a supplementation dose. Supplementation dose. There's a replacement dose. Okay. See, this supplementation dose is like, let's say your thyroid gland is functioning well. Okay, so like there's decreased thyroid function, but it is functioning at some extent. In Hashimoto thyroiditis, there's damage of thyroid gland, right? So there will, but still there will be some production of thyroid hormones. So we supplement the decreased amount of thyroid. We call it supplementation L-thyroxine, and this is usually less than 100 micrograms. So it depends on the patient. Okay, so if the patient's TSH levels are usually 5, 10, we start with 12.5 mg to 12.5 micrograms, we move to 25 micrograms. So our main aim is to make the TSH within range. Okay, if there's some activity of thyroid gland still there, we call it levothyroxine supplementation dosage. Okay, and this is usually less than 100 micrograms. If we have done thyroidectomy in the patient, we usually use less than 200 micrograms of levothyroxine. Okay, if in any patient we want to damage thyroid, we want to damage thyroid gland, right? So we can use 300 micrograms of levothyroxine. Okay, so in some patients of hyperthyroidism, we like sometimes we do have to damage the thyroid gland, so there will be no surgical complication in the patient. So we usually give higher dose of levothyroxine, that is 300 micrograms. Okay, so for supplementation, this is usually less than 100 micrograms. Okay, I hope this is clear. Okay, so this thyroid cancer. See, in the thyroid cancer questions, they'll give you thyroid enlargement, right? This enlargement will be painless for sure. This enlargement will be asymmetrical, and there will be lymph node involvement, right? See, so this thyroid gland might look like this. Okay, there can be some this is very bad drawing. Right, there can be some focus which is growing right here, and this is normal thyroid gland. So in patients of thyroid cancer, there will be thyroid enlargement. There it will be painless, asymmetrical lymph node involvement. Okay, there can be metastasis also. There can be lymph node involvement, and there will be no thyroid dysfunction usually. No thyroid dysfunction usually. So they in the question they usually mention euthyroid patients, right? Because the rest of the thyroid gland it is functioning normally. Okay, that's why the patients are usually euthyroid. There will be weight loss because of cancer, not because of some there are no hyperthyroidism signs. Okay, so this weight loss is not because of increased T3 T4. It's because this is a cancer, right? It needs more nutrition, so it absorbs from body, so that's why there's weight loss. Okay, and in thyroid cancer, the patients are usually euthyroid, so T3 T4 normal. Okay, so this was about thyroid. So in the thyroid we discussed about hypothyroidism, and in hypothyroidism most important is Hashimoto's thyroiditis. For hyperthyroidism we discussed about Graves. In Graves there were thyroid stimulating antibodies, and in Hashimoto there were anti-thyroid antibodies. And we discussed about diffuse toxic goiter and do the thyroid scan there. Right. Treatment of hypothyroidism to L-thyroxine is understandable. For hyperthyroidism we usually use anti-thyroid drugs. Thyroid drugs. For Krok exam, mercazolil is important. Okay, we can also use propranolol and do surgery. Okay, surgery, there can be some complication like thyrotoxicosis. There can be post-op hypothyroidism, and there can be recurrent laryngeal nerve damage. Okay, then we talked about thyroid cancer also. I hope till now we are clear, okay, about thyroid. So we are done with pituitary, we are done with thyroid, we are done with adrenal gland. Okay, let's move on to pancreas. Okay, so the main pathology for pancreas is diabetes mellitus. Okay, so we all know what is diabetes mellitus is. We all know sign and symptoms of diabetes, right? So they are polyuria. So there's increased urinary frequency. There can be polydipsia. If there will be more fluid loss via urine, there will be increased thirst. Right. So we classically study polyuria, polydipsia in patients of diabetes mellitus, right? And this mellitus means is hyperglycemia. So all these symptoms are because of hyperglycemia. Okay. So in any patient having hyperglycemia with these symptoms, okay, polyuria, polydipsia, we usually call it diabetes mellitus. Okay. So diabetes mellitus, there are two types. Type 1 diabetes mellitus and type 2 diabetes mellitus. For Krok question, they've asked the pathology behind type 1 diabetes mellitus. Okay, so we'll quickly discuss these types of diabetes. Okay, so in type 1 diabetes mellitus, what is there? So this is usually seen in children or young adults. Okay, in them there's damage. So see, this diabetes mellitus, okay, this is hyperglycemia, and which is the hormone which decreases the blood glucose level in the serum, that is insulin. Insulin is released by beta cells of pancreas. So if anyhow there's damage of beta cells of pancreas, okay, we call it type 1 diabetes mellitus. There's damage of beta cells, and this damage is because of anti beta cell antibody. So it is an autoimmune process. So what happens in type 1 diabetes mellitus is there's presence of anti-beta cell antibodies which damage beta cells of pancreas, so there will be decreased insulin. There will be decreased insulin production which causes hyperglycemia in the patient. And the patients are usually children or young adults. Okay. Type 2 diabetes mellitus is also there's hyperglycemia, but this is because of insulin resistance. this is because of insulin resistance. So there's release of insulin from beta cells, but the receptors of insulin, they are resistant. So that means the receptors are less effective. Okay, so they are not working properly. So there will be decreased in glucose intake of the cells, and it will cause hyperglycemia. So the clinical features we have already discussed. There will be polyuria, polydipsia, right? So if there's production of less insulin, which is seen in type 1 diabetes mellitus, so we also call it insulin dependent diabetes mellitus, IDDM. So type 1 diabetes mellitus, also known as AKA insulin dependent diabetes mellitus, right? Dependent diabetes mellitus, because all the patients of type 1 diabetes mellitus, they have to take insulin. So insulin is the mainstay of treatment, right? They have to they they are managed by diet therapy also, but all the patients, they mandatory have to take insulin. Okay. Type 2 diabetes mellitus, they are known as insulin dependent, non IDDM, non insulin dependent diabetes mellitus. So they can be managed by diet therapy. So any patient diagnosed by diabetes mellitus, okay, this is usually seen in old age people, okay, or middle aged. Okay, so any patient diagnosed by type 2 diabetes mellitus, they should be started by some lifestyle modification, right? Lifestyle modification means they should be they should be consulted with some healthy dietary habits, regular exercise. Okay, if this diet therapy and regular exercise, they are ineffective, then we move to pharmacological therapy. Pharmacological therapy, and but this pharmacological therapy is, we usually start with metformin. Okay, so we use, let's say a patient 50-year-old male has come to your OPD, and on objective examination, general examination, you have found that the patient's fasting blood glucose, okay, fasting blood glucose is, let's say, 140. You have done HbA1c, and that is 7.5%. I'm just making a case scenario, okay, clinical scenario. So you will firstly management, okay, so you will firstly talk about diet therapy, at least for 3 to 6 months diet therapy. If still the patient glucose level, they don't come into normal level, then you can go for metformin, right? We can add some other drugs like sulfanilamide also, sulfonamides also, right? Like glibenclamide, glipizide in the patients. Okay, in one question of Krok 2, the patient's HbA1c was very high. Okay, it was around from 10 to 15. Okay, it was very high. So we were directly starting from sulfonamides. Okay, so I asked this question with surgery teacher also, with internal medicine. She told if the patient is not obese and there's very HbA1c is very high, so we can start with these drugs also. Okay, start like these can be used for first line therapy also. Okay. So in some question they have asked insulin dosage also for type 1 diabetes mellitus. Type 1 diabetes mellitus, and the answer was 0.1 to 0.2 international units per kg of body weight, right? So if a child is 10 kgs, you usually use two units of insulin in the patient. Okay. if you are giving insulin to the patient, there can be some side effects of this insulin. The most important side effect is hypoglycemia. Let's say a patient is regularly taking insulin and one day the patient missed his food. Okay, the patient didn't eat anything and the patient still took this insulin injection. So there can be development of hypoglycemia. The clinical feature for hypoglycemia will be, there will be, patient will increased sweating, increased palpitations, right? There can be tremors, and these all symptoms will be given in a patient of diabetes mellitus taking insulin. So if a patient is taking insulin and these symptoms they arise, they are usually suggestive of hypoglycemia. And for diagnosis of hypoglycemia, you will do blood glucose level, and for treatment usually go for IV dextrose. Okay, so if a patient is on insulin therapy, he should be told about all the silent symptoms of hypoglycemia, which might be seen in patients if they missed if they have missed their meal and they have still taken their insulin. Okay, the insulin injection. Apart from this, the patient might develop hypertrophic lipodystrophy. Dystrophy. What this dystrophy is? See, usually we ask the patient to take injections periumbilically, right? And we ask the patient to change the location every time. Why do we why do we say this thing is, see, if the patient has taken insulin injection at this place, so there will be some adipose tissue hypertrophy, right? And next day patient is taking here, next day here, so there will be no proper lipodystrophy in the patient. But if patient is taking injection daily at the same place, it can cause hypertrophic lipodystrophy, right? So if patient is taking subcutaneous insulin regularly at one place, so patient might develop hypertrophic lipodystrophy. That is, there's increased increased lipocytes over there at that place particularly. Okay, so it will form like a nodule, so patient will feel something there under the skin. Okay, apart from this hypoglycemia and hypertrophic lipodystrophy, sometimes after many years, there can be development of insulin resistance also. So these three are the main complications of this insulin therapy, which are discussed in Krok 2 exam. Okay, let us discuss about complications of diabetes mellitus. See, in the Krok 2 question, they have asked a question from diabetes mellitus in every year. Okay, so that's why we are going into we are discussing this in depth. Okay, this diabetes mellitus topic. Complications of diabetes mellitus are, there can be diabetic nephropathy. We all know there can be damage of kidney in cases of diabetes mellitus. There can be retinopathy. Okay, polyneuropathy and visceral neuropathy. So why I'm writing this visceral neuropathy and polyneuropathy differently is, say, we all know there's damage of nerves in case of diabetes mellitus. Nerves damage in diabetes mellitus, right? But if there's peripheral nerves damage, we just call it polyneuropathy, in which we get this Stokes and gloves appearance, right? There's decreased sensitivity in the hands, in the feet there's decreased sensitivity, right? So that is known as polyneuropathy. Stokes and gloves appearance. Stokes and gloves, another thing. Okay, if there's damage of neural damage, So there's damage of some nerves of organs. Okay, so we call it visceral neuropathy. So how this will be explained in question is, in a patient of long standing diabetes mellitus, there will be some complaints of there will be some complaints related to visceral neuropathies, right? Penile erection dysfunction. There will be vertigo. That means there's damage of autonomic nervous system damage. Okay, autonomic nervous system damage present. Right. So this will be visceral neuropathy. In the last, we will talk about diabetes mellitus complications, emergency complications. Right. Emergencies. So we should know about DKA and high HHS. So DKA means diabetic ketoacidosis. So everything you can remember by name only, right? So diabetic ketoacidosis. See, just remember this is an emergency condition. Okay. So in this, there's hyperglycemia in the patient, which is very high, causing formation of ketone bodies. Ketone bodies means acetone, acetoacetate, beta hydroxybutyrate. Okay, and this is causing pH decrease. Okay, that means acidosis usually less than 7.35. Okay, just remember two things. We have DKA and we have HHS. In both these conditions, there will be hyperglycemia and there will be dehydration. Why do we have dehydration in these patients? Is, see, if there's increased glucose in the blood, there will be increased glucose loss. Uh, there will be increased urinary glucose loss, and if there will be more urinary glucose lost, there will be more fluid loss through urine. Okay, so there will be polyuria. There will be increased urinary urinary glucose loss and water loss. Okay, so in these emergencies, we'll get hyperglycemia and dehydration. The only difference between DKA and HHS is there's formation of ketone bodies, and in HHS there's no formation of ketone bodies. So ketone bodies are absent. Okay, so there and still there will be hyperglycemia and dehydration. For Krok, this much is sufficient. For treatment of both these conditions, we will give insulin. Okay, and we will use fluids. Usually we use normal cell line. Okay, insulin we use regular insulin. See, we usually study there are 5-6 types of insulin. Okay, they're fast acting, long acting, ultra long acting. Okay, but in all the emergencies we use regular insulin only, because this can be given IV. This is short acting. Short acting means it only works for 1-2 hours. Okay, but this is fast acting. So this is fast and short acting. Fast acting means whenever you give insulin to the patient, it will start showing its action. Okay, but the action will be for shorter duration. So in the question, in the question of DKA, in the question of HHS, they can ask you what will be the treatment. So in the treatment, sometimes they have written short acting insulin, sometimes they have written fast acting insulin, regular insulin. These all mean the same thing. Okay, so these regular insulin, short acting, fast acting, it is the same thing. Okay, that's the same, and you can use fluids. So we are done with, so guys, we are done with endocrinology. Okay, in the endocrinology, for pituitary gland, we talked about Sheehan. Okay, prolactinoma and hyperprolactinemia. Okay, these we discussed in gynec module also. For thyroid, just remember about Hashimoto, about grave, diffuse toxic goiter, thyroid carcinoma. Okay, in adrenal, remember about Cushing disease, Cushing syndrome, Addison, about cones, okay, about this thing, congenital adrenal hyperplasia, Pheochromocytoma, and in pancreas, or diabetes mellitus. Okay, in pancreas, I should have taken this topic in surgery, but I'll take it here also. Okay, there's pancreatic head cancer. See, like in Krok 2 exam, there are many questions related to pancreatic head cancer. Okay, so how to diagnose this is just you should be knowing the anatomy. Okay, let's say this is pancreas. Okay, and this is the pancreatic head. Usually there's this duodenum here. Okay, so in any case of pancreatic head cancer, it will obstruct. It will obstruct that the main duct which is bringing bile to the duodenum. If there will be pancreatic head cancer, there will be obstruction of biliary tract. Okay, and the patient will show signs and symptoms of jaundice. So patient will develop jaundice. See, in patient of pancreatic cancer and head of pancreatic cancer. Okay, so there is pancreatic head cancer. There's development of jaundice in the patient and it will be painless. So in any patient having painless jaundice, you should definitely think about pancreatic head cancer. Okay, because see, I told you most of the cancers they usually doesn't cause pain. Okay, they don't cause pain. Okay, so that's why there's painless jaundice, and whenever you see painless jaundice, this is the keyword for pancreatic cancer. Pancreatic head cancer. Okay, this painless jaundice. So we're done with endocrinology. Let's move to nephrology. We'll try to finish nephrology in 20-30 minutes, okay, because there are not much topics for nephrology. So for nephrology, you should know the basic difference between nephrotic syndrome and nephritic syndrome. Okay, so let's start with nephrotic syndrome. Just remember there's severe protein loss in urine in nephrotic syndrome. Okay, severe protein loss means there's 3.5 gram per day of protein loss. See, in the urine there should be negligible protein present in the urine. Okay, negligible means there should be around 30-40 micrograms. So 30-40 mg protein should be normally present in urine. But if there's more protein loss, so there will be decreased protein in serum. So there will be decreased protein in blood, decreased albumin in the blood, right? If there will be this much amount of protein loss in urine. Okay, so if you see severe proteinuria, okay, so you should think in terms of nephrotic syndrome. So what will the clinical features of nephrotic syndrome is? See, there's severe proteinuria. So because of this proteinuria, there will be decreased blood protein levels. Okay, so hypoalbuminemia. Okay, so because of this hypoalbuminemia, patient will develop edema. So they might not directly tell you the patient has edema, but they can tell you there can be pedal edema, there can be pleural effusion, there can be ascites in the patient. So this all edema symptoms they are because of hypoalbuminemia, right? Apart from proteinuria, hypoalbuminemia, there can be hypercholesterolemia in the patient also. Hypercholesterolemia. So for the patient of nephrotic syndrome, there will be proteinuria, usually more than 3.5 grams per day. There will be hypoalbuminemia and edema. These are the main signs and symptoms for nephrotic syndrome. For our Krok exam, the most important cause for nephrotic syndrome, there are two. There can be diabetic nephropathy. Okay, so diabetic nephropathy can also cause nephrotic syndrome, and there's renal amyloidosis. Renal amyloidosis can cause nephrotic syndrome. Okay, see, let us talk. So we have already talked about diabetic nephropathy, right? And because of prolonged diabetes mellitus, there can be damage of kidney. Okay, and this is we call it diabetic nephropathy, and this is one of the cause for nephrotic syndrome. For renal amyloidosis is, let's say, patient of any chronic disease. Okay, any chronic disease means like there can be chronic bronchitis, there can be chronic osteomyelitis. Okay, there can be rheumatoid arthritis. So any long-standing inflammatory disease. So the cells, they produce some abnormal protein continuously, and these abnormal proteins, we call it amyloid proteins. Okay, amyloid proteins, they are accumulated in kidneys, and there they cause nephrotic syndrome. We call it renal amyloidosis. Okay, secondary renal amyloidosis. Why do we call them secondary renal amyloidosis? Is, see, there is some disease outside kidneys, like chronic bronchitis, osteomyelitis, rheumatoid arthritis, and still all the abnormal cells from there, they all the abnormal proteins produced by these cells. Okay, these are accumulated in kidneys, and we call it secondary renal amyloidosis, and it is one of the cause for nephrotic syndrome. Okay, so for nephrotic syndrome, just remember two main causes: diabetic nephropathy and renal amyloidosis. What is nephritic syndrome is, just a second. Okay, nephritic syndrome. See, in nephritic syndrome also we get proteinuria, but this is not nephrotic range proteinuria. This is usually less than 3.5 grams per day. So there's mild to moderate proteinuria seen in nephritic syndrome. This is the main difference. Then apart from proteinuria, we also get hematuria. Hematuria means RBCs in urine. So normally there are just 1-2 RBC in urine, but if there's 2, 3, 4 RBCs present in urine, this is hematuria, microhematuria. There can be sometimes meat slope urine given the question, that is macrohematuria. So you can see blood in urine by yourselves. Okay. Apart from proteinuria, hematuria, we can get cylindriuria also in the patient. Cylindriuria. Okay, in the patient. And for the clinical presentation, there can be increased BP also. So for any renal disease, the cause of the disease is very important. If you have a history of the patient, you can easily diagnose the patient. So what can be the patient having, right? If the patient have some chronic disorder and then you are getting some urinary changes, it can be renal amyloidosis. If the patient has diabetes from long-standing diabetes, and now there are some kidney damage, so most likely it will be diabetic nephropathy. If the patient has nephritic syndrome, so there will be history. For our exam, the most important is post streptococcal glomerulonephritis or acute glomerulonephritis. Nephritis. So we have already talked about PSGN is, let's say, a patient having history of some streptococcus infection, right? Let's say they, they've mentioned quinsy, sore throat, okay, some skin infection. So any history of strep infection, and after 10 to 14 days, the patient has developed nephritic syndrome. So that so in that case, that is going to be post streptococcal glomerulonephritis or acute glomerulonephritis, right? For treatment of acute glomerulonephritis, they have mentioned firstly use antibiotics like penicillins. Okay, so this is the main treatment, and then you can also use steroids in some selective patients. So the main treatment for PHGN is antibiotics, because this is post streptococcal infection, right? So for nephrotic syndrome, just remember diabetic nephropathy and renal amyloidosis, all the silent symptoms of of nephrotic syndrome: proteinuria, then hypercholesterolemia, hypoproteinemia, then all the edema sign symptoms. Okay, for nephritic syndrome, just remember about PSGN. There must be a history of some throat infection or skin infection, some strep infection. After 10 to 14 days, the patient has developed nephritic syndrome. Nephritic syndrome means proteinuria, hematuria, cylanduria, and there will be increased BP also in these patients. Okay, for the treatment, just remember about antibiotics. Okay, I hope it is clear till here. Okay, so I'll tell you a clinical point here, okay? A clinical point. This is very important. So just pay attention on this point is, see, in whenever whenever a patient of kidney disease is there and that patient develops edema, this is usually morning time edema. This is usually morning edema, right? Okay, and if the patient come, if a patient of see, the most common causes of edema is either some renal disorder or cardiac disorder. Okay, if there's edema, usually evening time, or after exercise. So this is usually cardiac related edema. Okay, so morning time edema is usually kidney disease. It is not mandatorily that some cardiac disorder can't cause any morning edema, but this is usually a saying that morning edema should be because of kidney disorder, and if there's evening edema, it should be because of some cardiac disease. Okay, so after this acute glomerulonephritis, nephritic syndrome, we'll move to pyelonephritis. Acute pyelonephritis. Acute pyelonephritis. See, before acute pyelonephritis, we'll discuss about Pasternatsky sign. Pasternatsky sign. Right. See, in simple word, Pasternatsky sign means that there's renal area tenderness. Renal area. Yeah, lumbar area tenderness. Lumbar area tenderness. So in the lumbar area, there's painful. This area is usually painful. We call it Pasternatsky sign. Okay. See, this sign is for our Krok 2 question. This sign is usually positive in two cases. One is acute pyelonephritis. Nephritis. Okay, and renal colic. If there are some renal stones over there. Okay. So acute pyelonephritis or upper UTI. See, firstly let's discuss what is UTI is. So UTI is urinary tract infection. There are many patients of UTI in India. Urinary tract infection all over the world. There are patients of UTI, right? So what are the usual sign like usual problems, clinical complaints of a patient with UTI? They'll complain of fever. They'll complain of burning micturition, right? So these are the main complaints of the burning micturition, difficulty in urination, right? So we can suspect there's some urinary tract infection. Okay, so this urinary tract, though, it starts from this pylorus and it ends till urethra. Okay, so this urinary tract is very long, so there can be infection in upper UTI or lower UTI, right? So if you suspect urinary tract infection and if it's in upper part, okay, so there will be Pasternatsky sign positive, and you call it acute pyelonephritis, right? Low, if it's lower part, so there will be Pasternatsky sign negative, call it acute cystitis. See, in any patient of UTI, you are going to do the urinary examination, right? In urinary examination, there will be bacteriuria, there will be leukocyturia, right? This is because of infection. Pyuria can be there. And in Krok 2 question, you have to find the location of the infection. So in any patient coming to you with complaints of fever, burning micturition, you do objective examination, Pasternatsky sign positive, you should think of upper UTI, that is pyelonephritis. If it's negative, there will be lower UTI, right? Urinary examination will be bacteria present in urine, bacteriuria, leukocytes will be there, leukocyturia, and there can be pyuria in the patient. Patients of acute cystitis will not have Pasternatsky, so there will be no lumbar area pain. Okay, so the pain will be in the suprapubic, so in the urinary bladder area, right? Suprapubic area tenderness will be there. Okay, so by this way you can differentiate between acute cystitis, acute pyelonephritis. Okay, so upper UTI and lower UTI. Understood? So let's say if you have not treated the patient of acute pyelonephritis properly, so not treated properly. Give me a second. So not treated the patient of acute pyelonephritis properly. So this acute condition can progress to chronic pyelonephritis. Right. So this all difference between acute and chronic is it's on the duration. So let's say a patient having these symptoms like fever, burning micturition, okay, leukocyturia, bacteriuria, okay, lumbar tenderness from a long period of time. Long period of time means they can be like months, 5 months, 6 months, and from 5 to 6 months, the patient having these symptoms. So we'll make the diagnosis of chronic pyelonephritis. Okay. So the only difference between acute pyelonephritis and chronic pyelonephritis will be the symptoms will be not so severe in chronic pyelonephritis. There will be mild fever. Okay, in acute pyelonephritis, the symptoms usually develop acutely, so all the symptoms will develop in less than 14 days. And in chronic pyelonephritis, all the symptoms will be during a long period of time. So let's say for months. Okay, so the symptoms will persist in the patient for months in case of chronic pyelonephritis. Okay. Then in urinary bladder, we have talked about acute cystitis. The sign and symptoms will be same of UTI, and there will be suprapubic area pains, pubic area tenderness. Okay. There for our Krok, they have mentioned this urinary bladder tumor also. Just remember, all the tumors, they are usually painless, they develop very slowly, so they don't make much symptoms. But in case of urinary bladder, there can be hematuria and there will be macrohematuria. So all the blood will be visible by naked eyes. Okay, so macrohematuria will be there. In case of urinary bladder, there will be no pain, so painless. And by anyhow, at the end, they will give you some history of benzene compound usage in the patient. So benzene, it is the most important risk factor, most common risk factor for this urinary bladder tumor. Okay, then there's some kidney tumor cases given. See, any tumor, it is in, so there will get all the general signs of cancer, right? There will be weight loss, some urinary changes, painless growth can be felt in lumbar area. This will be suggestive for kidney tumor. There is one pediatric renal tumor they have discussed is Wilms tumor. Okay, so in Wilms tumor is, see, let's say this part here we have a Wilms tumor. So in the lumbar area, there will be a growth seen in pediatric cases. We call it Wilms tumor. Okay, and this is known as ballotment sign. So ballotment sign is just feeling of some mass in the lumbar area. Okay, so ballotment sign positive. This is suggestive for Wilms tumor. So in nephrology, just the important topics will be nephrotic syndrome and diabetic nephropathy, and renal amyloidosis. For nephritic syndrome, just remember about PSGN. Then acute pyelonephritis, chronic pyelonephritis, acute cystitis. Okay, then this urinary bladder tumor, then Wilms tumor and renal tumor. Okay, any doubts till here? Any doubts? Okay, so we'll finish here. Thank you. Oh, sorry. We are left. We missed this thing. Excretory urography. And this maturating cystourethropy. Okay, we'll just quickly discuss these things also, then we'll finish our lecture. Then we'll finish our session. Okay, see, let us discuss about this excretory urography first. So I'll tell you quickly what does it mean is, so that you can answer questions easily. See, if you have given IV contrast to any patient, okay, and this IV contrast, it is excreted by kidney. So kidney is excreted, then it will come to your urinary tract, and then it will come out of urine, right? So in excretory urography is, you give IV contrast to the patient, and then this contrast will be excreted by kidney, and so that you can see all the path of the kidney. You can see the kidney functioning also, so how much is it functioning. So to check the anatomy of kidney, you can do this excretory urography. To check this physiology of kidney, you can do excretory urography. So we usually use excretory urography for if you feel there's duplex of this ureters present. Okay, agenesis of renal present, agenesis of kidney is there. Okay, there are some problem with anatomy or some problem with physiology, you use excretory urography. What is micturating cystourethrophy is urethrophy is, let's say this is your urinary bladder. Okay, make it here. These are your kidneys. Okay, this is your bladder, and this is urethra. So you push contrast through urethra. So contrast through urethra, and this contrast will be there, and the patient is asked to micturate it. Micturate is means urinate. Okay, so usually these are the valves here. Okay, usually all this contrast will come out like this only, right? So it will tell you the passage, the normal passage of lower urinary tracts. Okay, if this contrast will go upward also, so there's some insufficiency of this valve here. Okay, so to check valvular insufficiency, we can do micturating cystourethrophy, right? And what will be the complaint of the patient for valvular insufficiency? There will be recurrent urinary infections in the patient. Okay, so this is one of the important cause for recurrent urinary infection, this valvular insufficiency here. Okay, so guys, we are done with our endocrinology and nephrology. Okay, so just send all the doubts in the WhatsApp group. If anything left, we'll take just one more session tomorrow, then we'll finish. Okay, I'll try to upload this pediatrics video today only. I'll upload pediatrics video today. I'll make it right now, and then we'll take one more session tomorrow on hematology, this GIT pathology. Okay, and we'll cover what else we can cover apart from GIT and hematology. We will cover rheumatology also tomorrow. Okay, thank you. Bye.